All right, Parkinson's disease is a degenerative neurological disorder in which the brain cells that normally produce the neurotransmitter dopamine die off. When these cells die, the brain loses its ability to control movement, which leads to tremors in the hands and feet. All right, this is the question. Remember, this is what I always do. I ask questions. All right, everyone, point to your brain. Point to your brain. All right? You're sitting next to somebody, point to their brain. Point to their brain. Now, if you believe that there's nothing up there, point to their seat. And that might be where they're. But let me tell you, all of you were wrong. Every single one of you was wrong. You pointed up here. That's not the brain. I'll show you that in a minute. So what are the components of the brain? Does anybody know the components of the brain? Huh? Cerebellum. He said cerebellum and the cortex. He's missing one, but then we'll go through that. All right, there are no therapeutics to treat the root cause of the disease, but there are drugs to help relieve the symptoms. This is Parkinson's. Patients frequently receive a medication called levodopa, also called L-dopa, which nerve cells can use to boost the brain's dopamine. People with Parkinson's disease may eventually lose the ability to walk, talk, and can experience memory loss, behavioral differences, chronic pain, depression, and fatigue. There are over 930 Americans with the disease, and it strikes people usually over the age of 60. Parkinson's disease brings up a lot of questions for most people. It's chronic and progressive, and the body, and it destroys the nerves within certain parts of the body. It occurs when the nerve cells in the body don't produce enough dopamine, the chemical which they believe, let me say it, they believe, coordinates movement and feelings of motivation and reward. We saw this morning that did you need dopamine to produce movement? Did I show anything with dopamine? Did I show anything with dopamine? No. I didn't give that kid any drugs. It wasn't me. And you know his mother's going to kick his little tail if he gets any drugs. I want you to remember this slide. Symptoms usually start gradually and worsen over time and can include unintended or uncontrolled movements, shaking such as tremor in one hand, stiffness, difficulty with balance and coordination, slowed speech, loss of facial expression, small and difficult to read handwriting, swallowing changes, postural changes, low blood pressure, sleep problems, and constipation. I want you to remember these things, okay? These are things that they say are a problem with Parkinson's disease. Others are such as depression, hallucinations, dementia, urinary problems, constipation, skin problems, localized muscle pain. Walking is affected. Person stops in the middle of their stride. So they're walking along and then stop. They freeze in place. This is known as phenestation. This is what it looks like. They have a stooped posture, masked face, rigidity in the back, forward tilt of their trunk. Flexed elbows, reduced arm swing. That's the first thing, just to give you an answer, that's the first thing I look for in every patient with Parkinson's disease is an arm swing. Do they have an arm swing? Tremors in the legs and feet, slight flexed knees, and shuffling gait. You take, now I do not diagnose these patients with Parkinson's. They come in and tell me that their neurologist diagnosed them with Parkinson's disease. That way, I don't get in trouble, okay? If they want to tell me they got Parkinson's, they can tell me they got Parkinson's, okay? They say there is no cure, quote unquote, but medications can help. Surgery or deep brain stimulation can help with severe cases. Parkinson's is likely, this is the NIH definition, is likely a combination of genetic and environmental factors. There's no clear exposure that can be identified as the straightforward cause. So if there's no straightforward cause, how can you tell me that it's an environmental factor? How can you tell me that it is a genetic factor? What if it's something else? Can it be something else? They told us Tourette syndrome was a genetic factor, and they spent $80 million, which they didn't give me, right? And we find out that it doesn't work. That's not what it does. So remember the thing, it's not that you're uneducated, it's that they're educated just enough to believe what you've been taught, but not educated enough to question what you have been taught. So what is the life expectancy of Parkinson's disease? Usually, it is a contributing factor to death. And back in '67, the life expectancy was only 10 years. Now it's about 14 and a half after they're diagnosed. What stage does dementia start? Usually around 50 to 85. It's one of the side effects of Parkinson's. Up to 80% of people with Parkinson's develop dementia. Do you know that periodontal disease can cause dementia? Did you know that? So, 80% of those with dementia may have a problem within their mouths. They didn't look. They didn't ask the dentist, did they? Did they ask you? They just said, it's a genetic factor. Oh, it's an environmental factor. They didn't ask you. Now, there's a finger test for Parkinson's. There's a toe tapping test. There's a walking test. There's a pull test and a pill rolling test for Parkinson's. What they do is they have you tap back and forth, like this, both hands. Back and forth, back and forth, back and forth. And they want to see how coordinated your movement is. They have you do a toe tapping. First it's heel, toe, and then it's toe, toe, toe. Do you have that coordination? They have you do a walking test. You walk to a certain degree and come back, and they see how you walk. They see what they look for is they look for the hand and arm tremors. That's the first thing they look for. First thing I look for. Retropulsion test. What they do, they stand behind you, and the patient stands in front of you, and they pull the patient back. The patient's supposed to stop, but most Parkinson's patients do not stop. They almost fall down. That's why you, as the doctor, has to stand behind them. And then they have the pill rolling. That's one of the other tests. They look to see if you do a pill rolling test. Treatments for Parkinson's. They have the medications, They have the deep brain stimulation and brain surgery. Parkinson's disease, the medication that they use is a synthetic medication that has carbidopa and levodopa, and it treats tremors associated with the disease. Carbidopa and levodopa, synthetic. My doctor said right before lunch, he said, if you can use a natural one, use a natural one. We'll see if that's possible. Benzodiazepam temporarily relieves tremors. What's it doing? Temporarily relieving tremors. What was the other one? Carbidopa, levodopa. Relieves tremors. Side effect, sleepiness and poor concentration. Ability to perform daily, difficult ability to perform daily tasks. Beta blockers, also to treat tremors. Okay, we got 3 medications that treat tremors. What else is it treating? They're not treating anything else but the tremors. Anti-seizure medication, primidone. When beta blockers are not effective in reducing tremors. Why? It's only tremors that they're reducing. Botulism toxin, all types, it's given to all types to treat tremors. Is there a theme here? Is there a theme with their medications? They're treating tremors. Dopamine agonists. Okay? Another treatment is deep brain stimulation surgery. Again, I showed you this morning. They drill a hole in the top of your brain, put these lead wires all the way into the subthalamic nucleus, and then run the wire under your scalp, down your neck, into a battery pack in your chest. They call it a pacemaker. But then they fine-tune it a few weeks later, like a radio, to see if it reduces the amount of tremors. Only about 50% effective. Thalamomy. Permanent destruction of the thalamus. How would you like to have part of your brain electrically removed? I don't think so. That's why it's not done too often. But if they do both sides, it causes a speech problem. And here's your subthalamic nucleus next to the substantia nigra, which is where they state, which is part of the basal ganglia, which they state this is where the dopamine is being lost. Now, what's it above? Directly above, right in the picture there. Directly above the brainstem. Supposedly disorders of the basal ganglia. There's dystonia. Everyone know what dystonia is? Yes? No? Huh? No. Okay. See that? Somebody's awake. I'm going to make all y'all stand up. No, dystonia. There are multiple types of dystonia. There's cervical dystonia, which means the head is twisted in one direction and the patients can't move it. Guess what? It can be done without affecting the basal ganglia. I've done it. Other doctors have done it. Okay? Dystonia of the hand. Hands are twisted. Arms are twisted. Feet twisted. They can't move. That's what a dystonia is. Tremor. Well, we understand what tremor is. Myoclonus. Very much the same as a dystonia. Dyskinesia. Same as almost like a tremor. They difficult for them to walk. Tics and Tourette's. This is right from the NIH. Tics and Tourette's is a product of a poor basal ganglia. Did you notice that I worked on the basal ganglia this morning? I was really working hard on that basal ganglia. I took that kid's head and turned it all the way around. Worked, didn't it? Parkinson's disease. They say that's from the basal ganglia. Let's take a look. Here's the hypothalamus, there's the basal ganglia. And like I said, the thalamus. The dopaminergic neurons are a small but important group of neurons in the brain that are thought to play a key role in development of Parkinson's disease. These neurons are vulnerable to degeneration due to their extensive branching and the large amount of energy required to send nerve signals and recharge them. When these neurons run out of energy, they degenerate. How many old people here can actually walk? Did you run out of energy? No. Didn't happen. So this is their depiction of Parkinson's disease. And the neurons have a large amount of dopamines that go into the receptor and cause normal movement. We did that with the Tourette's kid this morning. We worked on his increasing that dopamine. But in Parkinson's, they say you lose the effect of the amount of dopamine, which means there's a movement disorder. That didn't happen this morning, did it? Now here's a cut section of the midbrain. Here's the substantia nigra. And in the substantia nigra, you see that there is a loss of the substantia nigra means dark cells. You notice that the dark cells have dissipated in the Parkinson's disease. Why? I don't know. I'll be honest with you. I don't know why it decreases, but it does. Or the amount of has decreased. The Parkinson's disease is characterized by a progressive loss of dopamine in the substantia nigra. The most common treatment of Parkinson's involves trying to restore dopamine levels in the basal ganglia, but dopamine doesn't cross the blood-brain barrier. I can never say it right. Levodopa, though, is the therapy that can help alleviate these symptoms, but it doesn't improve the progression of the neural degeneration. So the levodopa will cross the blood-brain barrier, but the progression of the degeneration continues. So is that the portion that actually causes the movement to have a movement disorder? You have to think, question everything. Dopamine plays an important role in brain function, such as voluntary movement. But if you're walking and you have a tremor, is that a voluntary movement? The tremor, is that a voluntary movement? It's an involuntary movement, correct? So if the dopamine is to help with the voluntary movement, what activates the involuntary movement? What was that? Well, the dopamine is supposed to be for voluntary movement. But what causes involuntary movement? What did the children or the people that had the Tourette syndrome this morning? They're taking away involuntary movement. What did I give them dopamine? Say that out loud. What nerve? Auricular temporal nerve. Okay. Somebody's paying attention. Love it, love it, love it. All right? Mood, reward, addiction, stress. That's what they say dopamine is, or dopamine can do. But you ask the question, is there another part of the body that can do the same thing? It's okay. Where did he go? He left. But he said the cerebellum and the cortex. There's one other part. It's called the reticular formation. See, nobody thinks about the reticular formation. The reticular formation is very, very, very important because, remember that slide I told you to remember? This is when the reticular formation is malfunctioning. Unintended and uncontrollable movements. Stiffness, difficulty in balance and coordination. Slowed speech, facial expression, swallowing changes, posture changes, low blood pressure, sleep problems, constipation. Hello. So there's a second portion of within the brainstem that can cause these symptoms to occur. Now, guess what nerve can cause excessive input into the reticular formation? How many of you are dentists here? How many of you work with a nerve called the trigeminal nerve? Every dentist should have their hand up. You cannot do dentistry without affecting the trigeminal nerve. The trigeminal nerve is the only cranial nerve. The only cranial nerve that has primary afference into the reticular formation, which means it has a one nerve access to the reticular formation. It has neurons that go directly to the brainstem. Now, suppose I have a problem in my temporomandibular joint. Can that affect the reticular formation? Absolutely. What did I just say? Periodontal disease. Does that destroy bone? Periodontal disease destroy bone? And can periodontal disease cause dementia? You're destroying the bone supplied by the trigeminal nerve, which then goes directly to the reticular formation, and these things can happen. The same things that they say in Parkinson's disease, the same things can happen with the trigeminal nerve having a poor input into the reticular formation. It's like a lightning bolt hitting you've seen those movies where it hits the transformer and the transformer explodes all over the place. That's exactly what's happening. You have excess input into that area. Excessive reticular formation input causes disturbances in the function of the reticular formation. Many of the neurons in the reticular formation are multimodal and respond to various modalities of stimuli, allowing them to integrate many different types of senses and relay them to higher cortical areas. The reticular formation, you know what it looks like? It looks like a fishing net. That's what it looks like. Can you tell me where in a fishing net you can actually follow to go from one area to another area? Difficult. Same thing with the reticular formation, but we are fearfully and wonderfully made. So we can find what causes or what may be one of the factors that can cause the reticular formation to have poor input and relay these to cortical areas. The reticular formation relays directly to the cortex. So the reticular formation actually has serotonin. Guess what serotonin regulates? Huh? Dopamine. Hello there. Somebody's paying attention. Serotonin is the regulator for dopamine. And if serotonin regulates dopamine, that means something's happening, could be happening within the reticular formation, causing a loss of dopamine. When serotonin is low, dopamine is high. When serotonin is high, dopamine is low. Now, if you have a constant input into the reticular formation, say from the trigeminal nerve, I'm just using that as an example. I'm just using that as an example. Constant irritation or constant input causes the serotonin to constantly be released. Serotonin is high, dopamine. What causes Parkinson's disease? As according to the NIH, low dopamine. Interneurons that make up the vast majority of the reticular formation have a vast connectivity. Each neuron within the reticular formation makes synapses with many other secondary neurons, causing an exponential number of connections form the network-like structure. That's what I was just telling you. It looks like a fishing net, the reticular formation. The reticular formation centers are associated with cranial nerve nuclei of the trigeminal nerve, of the facial nerve, the glossopharyngeal nerve, the vagus nerve, the hypoglossal nerve, to coordinate complex tasks of respiration. So, first one is trigeminal, because the other ones, you have secondary input into the reticular formation. The trigeminal has primary. Okay? The only center with primary afferents to the reticular formation. The central nerves, the central areas, which research has determined to play a role in autonomic rhythms and are located caudally to the reticular formation near the junction of the pons and the medulla. Where does the trigeminal nerve originate from? Pons or medulla? Pons, right? Exactly. Somebody remember their neuroanatomy from college, from dental school. Reticular formation influences many of the cranial nerves, motor nuclei, as well as project to various structures of the limbic system associated with emotional behavior. We call that mood. Associated with memory, dementia. Associated with autonomic behaviors, breathing. All signs that they tell us are from Parkinson's disease. A reticular formation, premotor neurons are present that project via the long descending axons to the spinal cord, motor neurons which participate in autonomic functions. When you walk, it is not the brain that causes you to walk. That's not the part that makes you walk. It is the reticular formation that actually makes you walk. The brain has to send signals to the reticular formation. The reticular formation then coordinates the movement. If I were to walk or rely on my cortex to tell me what to do in walking, I'd have to say, okay, raise this foot, put this foot down, heel toe, arm swing here, arm swing there, keep your head up, eyes forward. None of that. The brain is not that coordinated. But guess what is? Reticular formation. It's autonomic, automatic. You can do it. What they've done back in the old days, they actually separated the spinal cord from the brain of a cat and then put him on a treadmill, and the cat was still walking, which shows that it is not the brain or the cortex that actually coordinates the movement. It is the reticular formation that coordinates the movement. What other tract controls movement? He was right, the cerebellum. What are the defects of the cerebellum? Signs of cerebellar dysfunction are the following: ataxia, unsteady, incoordinated posture and gait. Does that sound like Parkinson's? A disorder control of force and timing of movement, leading to abnormalities in speed, range, rhythm, starting and stopping. What did I tell you about Parkinson's? They have a freezing gait. They stop in the middle of their walk. When you do the retropulsion test, you pull them back, they can't stop. Titubation is tremor of the head, hands, and torso, and is of cerebellar origin. This is not my research. This is research out of neuroanatomy books, including dysarthria or speech problems. Does that sound like a portion of Parkinson's disease? Guess what nerve goes to the cerebellum? Anybody have an idea? The trigeminal nerve has input into the cerebellum. Okay, so fibers transmit information to secondary afferent cell bodies in the spinal trigeminal nucleus, plus the principal nucleus, which is in the brainstem. Axons from the trigeminal cerebellar tract ascend to the cerebellum. Excessive input into the trigeminal nerve gives rise to excessive input into the cerebellum, causing dysfunction of cerebellar origin. It should say origin instead of function. So tremor, not necessarily from the cortex. It could be from the cerebellum. Okay? The speed and walking. The Parkinson's disease drug, levodopa, such as pergolide and bromocriptine. It can be dangerous, however, as they may cause symptoms such as tardive dyskinesia. Anybody know what tardive dyskinesia is? Tardive dyskinesia is where your tongue cannot stop moving outside of your mouth. So you look like this all the time. And if you give enough of this drug, it can become permanent. Akathisia, restlessness, especially of the legs. Tonus, or set of muscles, rhythmic contraction and relaxation. That's clonus. So now, let's answer the question. What constitutes the brain? The cerebral cortex, the cerebellum, and the reticular formation. That is your brain. That is actually their definition. But when they treat Parkinson's disease, they're only treating one area, which is in the cortex. What nerve has connectivity to all parts of the brain? Trigeminal nerve. Trigeminal nerve goes to reticular formation. Trigeminal nerve goes to the cerebellum. Trigeminal nerve goes to the thalamus, which goes to the cortex. Can trigeminal nerve produce aberrant signal to other connections? Absolutely. We just discussed that. If you have a joint problem, periodontal disease, root canals. How many people get in a bad mood when they have a root canal, need to have a root canal? A lot of people. Can Can a disruption of the trigeminal cause disruption of the cerebral cortex, cerebellum, and the reticular formation? That answer is yes. Can normalizing the trigeminal nerve help relieve or normalize the three parts of the brain to a degree? Now, each part, the cerebellum has to, the cortex has to communicate with the cerebellum, and the cerebellum has to communicate with the reticular formation, and the reticular formation has to connect with the cerebral cortex again. So they all have to have a certain segment or be in harmony with one another. But if the dopamine is in the cortex is not there, you have an incoordination. Incoordination can now affect cerebellum. Incoordination can now affect the reticular formation. What can't the trigeminal nerve do? What can it do? It cannot do. It cannot repair or restore the damaged substantia nigra dopamine producing cells. It can't, because we're not close to it. Can the dopamine cells be repaired or replaced? Can they? Well, synthetically, what do we use? Carbidopa, levodopa. But can it be replaced naturally? My doctor said, if you can replace things naturally, do it. Synthetic is not the way to go. But can we replace the dopamine naturally? Question: how? There is a seed out of Africa called Mercury-Free. They make it into a powder, and it's put into a beverage such as water. If you want to make it real powerful, put it in green tea. Mercury-Free is a creeping vine that can be found in India, the Caribbean, and Africa. It's also known as velvet beans. The seed of the mucuna plant are known to naturally contain levodopa, also known as L-dopa, and has a high concentration. It is the highest concentration naturally. And levodopa is the precursor to dopamine. Western medicine uses a synthetic form of L-dopa to boost the dopamine levels in Parkinson's. 45 grams of mucuna can actually do the exact same thing, as much as 1 teaspoon. Unlike dopamine, levodopa crosses the blood-brain barrier. Levodopa converts to dopamine in both the central nervous system and the periphery. That's why they have to have two. The carbidopa prevents the levodopa from becoming dopamine in the central nervous system, so it can cross the blood-brain barrier and then become dopamine. So yeah, that's why they have to have so much of it. You can have up to 300 to 1,200 milligrams a day, and then they titrate it, if need be, even higher. Recommended titration schedule is supposed to be 100 milligrams a day for 3 to 4 days. Adverse effects of levodopa treatment is nausea, dizziness, headache, somnolence, confusion, hallucinations, delusion, psychosis, and agitation. That's according to the NIH. I didn't make this up. NIH told you. But they didn't tell you about the mucuna-purines. Mucuna-purines, the preliminary evidence shows that mucuna may be in some ways superior to the synthetic levodopa. Mercury-purines resulting in a lower incidence of dyskinesia compared to treatment with the same amount of synthetic levodopa. Mercury-Free powder, more effective than the same amount of isolated levodopa for restoring the brain levels of dopamine, L-dopa, norepinephrine, serotonin, and has a greater neuroprotective activity. They don't tell you about that, did they? They tell you about the synthetic one. Why? Because they're making money on it. Levodopa can cause extensive DNA damage. Mercury-Purines may have antioxidant and metal-chelating properties, potentially mitigating the risk of DNA damage. So the natural actually has a better success rate than the synthetic. Now, with levodopa, you have all those side effects. They have not found one person so far that is allergic to Mercury-Purines. Not one. Not in all the research I've read, at least. And here's the research. If you want a question, here's the research. I did not make this stuff up. It's right there. Parkinson's disease, they give you anywhere between 5 and 45 milligrams, or 5 milligrams of Mercury-Purines, a seed powder. Usually, what I do is for the patients that I do, I use my appliance that I showed you this morning, plus I use Mercury-Purines. So I give them, I titrate that upward. So the Mercury-Purines contains the L-dopa and is usually 2 to 3 times more potent than the equivalent of the synthetic levodopa. And you can use it in conjunction with that, but I'd be very, very careful, because the Mercury is much more effective, and if it's much more effective, it will can cause problems. All right. I've been talking a lot. I'm going to show you a case. This is a 52-year-old previous cab driver diagnosed by a neurologist with Parkinson's disease. Difficult gait mobility, right arm and left arm with a mild tremor. Dystonic neck posture. Posture was getting worse. Coordination issues, brain fog, and rigidity. Like I said, I don't diagnose them. They get diagnosed by and come see me. Matter of fact, this gentleman here, his son, he's from Jordan, across the way, across the sea. His brother saw some of the stuff that I do online, called his son and told him to bring his father over there. His son is an oral and maxillofacial surgeon at University of New York. And he went, got his father, and then drove him down here. His son is actually over to the right of the screen, watching all this. So I'm not making this up. Notice what's the first thing I say I look for? Arm swing. Does he have any arm swing? None. Slow, bradykinesia. Dystonic head posture. His head is literally on
one more time.
On his shoulder. Okay, go ahead and grab a seat in the chair. Good. All right, you did good. Now here we give him his device. I'm supposed to give him some dopamine with it, right? Okay. Good. Very good. Your chin's not on your chest?
No.
All right. I want you to turn your head to the left now. Good. Good. All right, we're going to take a walk. All right, you're going to go. What's the first thing you see? One more time. Notice the arm swing. Now this is the best I thought I was going to get. I thought you'd have to come back, all right. Come back. Real good. We're going to do a... But this happened. Well, look at you. Go ahead, one more time. One more jog. One more jog. One more jog. Real good. Excellent. All right. Tell me what you feel. What did you see his head? Where did you see his head? Straight ahead. He was looking straight at me. He said, I feel much better. He's diagnosed with Parkinson's disease. Diagnosed with dystonia. I didn't give him any dopamine, didn't give him any other medication, but yet he was able to change his gait, changed his walk, changed his arm swing, changed his head posture, changed everything within, and this is minutes, okay? It doesn't happen like that all the time, but come on. You're a dentist, you can do the same doggone thing. That's what you should do. This is where you should be. You are the greatest neurologist in the world, and you just don't know it. Let me go back one. 59-year-old man. Previous drummer diagnosed by a neurologist with Parkinson's disease. Difficulty with mobility. Right arm and left with moderate tremor. Gait had a drop foot. Posture was continuing to get worse. Coordination issues were getting worse. Brain fog, rigidity, slowness, can't judge pressure changes. MRI of the brain showed no significant changes in the substantia nigra. But he was diagnosed with Parkinson's disease. TMJ symptoms of clicking on the right side. Lost number 31 in his 20s. Drools on the right side, inability to open his mouth very wide, dysphagia or difficulty swallowing, right occipital pain, panoramic was brought in by the patient. Treatments tried. No medications. He didn't try the carbidopa, levodopa, synthetic ones. High dose vitamin B injections, no effect. 1 year acid therapy, I don't even know what that is. No effect. Methylene blue for cognition, not helping. This was his panoramic x-ray. If you look at the TMJ, what do you see? You see condyles, right? What did I say everybody gets in my office? MRI, correct. You cannot and you should not rely mainly on an x-ray or a CT scan because all it shows is bone and it does not show the soft tissue that's going on with you, with that person. This gentleman had if I had just looked at this, I'd have said, well, you're not too bad. Everything looks, the condyles look fine, so forth and so on. There's the condyle that I'm talking about right there on the left side. On the right side, I apologize. When you look at the MRI, you see that his condyle has flattened. And then you look and see the circle, the red circle there. That condyle has been wearing away for years. Looks like it's rat-eaten. I'm pointing it out to you. It looks like it's rat-eaten, which means that condyle has been posteriorized for a multitude of years. Okay? He wore out his condyle. The nerves in that bone have all been fried almost. And guess what nerve is back there? Trigeminal. What nerve though? The auriculotemporal nerve. Oh, I love you people. I love you people. All right? So it's been wearing out. The nerve is being worn out. The condyle is being worn out. And you will actually see this patient. Now, he gives me permission. If I film somebody, always get permission. Do I have your permission to film?
Yes.
All right. Now, what you notice is his hand.
My name is John.
Look at the amplitude of his tremor.
Next month or two, I was diagnosed with Parkinson's at 57. I was a lineman with the phone company. I had to eventually leave my job. Saw a general neurologist and a movement disorder, what is it? A movement specialist, who said I was pretty much textbook Parkinson's. Mainly affects my right side as of now. I get it all on my left, but very slightly with the tremors. Trying to go about it in a more holistic approach. So we haven't really done too much medicine-wise. Doing a lot of supplements, hyperbaric chambers, saunas, stuff like that. And they've helped me cognitively, but I still struggle with hand motions and eating and getting dressed. And my wife does a lot of research and found out about Dr. Sims, so we thought we'd give it a try. And we came in for the test, and there was improvement, immediate improvement with the way he tests with the popsicle sticks, I guess they're called, or tongue depressors, whatever they are. And so we're going to give the appliance a try and see how it goes.
What happened when we tested with the tongue depressors? What happened to your?
The tremors in my legs basically stopped, and it seemed like the tremors in my arm, although it was still there, decreased pretty significantly. And didn't notice that too much with the walking yet, but we'll see what happens with that.
Okay. What did we see on your MRI?
We saw that my TMJ disc is completely out of place at the, I believe he said the 9 o'clock position instead of the 12 o'clock position. And bone on my right side.
Which is where everything started in his body, which is his dominant side. That's where the tremors began.
Yeah. Is there anything else?
Okay, we're going.
You did a good job.
Yeah, you did a great job. All right, we're going to pause, and then we're going to get your orthotic.
My name's Chris.
This is immediately after we've put the appliance in for the first time.
Look at the amplitude.
Well, my legs definitely feel less of the tremor. They're slightly going. And my arms have the tremor still, but it's less. And that's about it.
Okay. That's all we need.
Okay.
I concur.
Yeah.
I agree.
Doctor, okay, doctor. You concur. All right. Good deal.
Now, if I showed you all great cases, I'd be lying to you. I'm not going to show you all great cases. Some cases take a little longer than others. But what you notice is that he doesn't have that tremor when he walks. Still had the foot drop, which I couldn't. It was a balance between the tremor
One more time.
and the
last
foot
one.
drop. No arm tremor. Still no arm swing, but he needs a little more time. This is just appliance. He didn't do the L-Dopa like the Mercury-Free like I told him to do. He was hesitant.
Very good, very good.
But just to keep that in mind, here's a patient that has nothing but the Mercury-Free. "90 minutes afterward. Now you tell me the natural versus the synthetic. And there are no people so far that in the literature that is allergic to the Mercury-Free. You can actually get it on Amazon. Seriously, it's. Do you think the Parkinson drug companies are going to give you this because it costs pennies versus, carbidopa, levodopa? Here's we talked about this morning, the different books that I'm in. Remember, it is www.drsimsdds.com, and then you put this code in. I should have put it in for you, but you can get 10% off for the rest of this week. This will tell you everything. Show you everything about the trigeminal nerve, the temporomandibular joint, the different cranial nerve, even in autism and movement disorders. So I want to say thank you.